Disclosures. So historical context for osteotomy. I mean, we know if we read the papers that this is something that's been around for a long, long time, but of course was principally concerned with deformity in its early years. In the 20th century, osteotomy became more about knee pain, arthrosis, but the 21st century has been much more about diversity and pushing the boundaries back, and we're talking about articular cartilage work, ligamentous work, we've talked about slope change today, and that as a very valuable tool that we can employ it. There's so much more we can do with knowledge and evidence supporting us, safety with improved techniques, less fear as the safety elements have improved, and an expansion of the indications. So the results of, if we look back 12 years, these results really apply to the previous 20 years of osteotomy, which were perhaps slightly outdated techniques, but still some very impressive 15-year survivorship there. They're the lime green bars on the histogram. But then if you go forward and more recent reports, systematic reviews looking at 30 articles of over 7,000 HTOs, there's very good reports of even 20-year survivorship now. So these are not sort of whimsical one-offs anymore. They are predictable operations. And if we follow the guidance and stick to the rules, we find good results are very, very to be expected. So we've literally just published this consensus with KISTA. It's the ESCA European consensus for osteotomy around the painful degenerative varus knee. So it concentrates really on the simple, most common application of osteotomy in our practice, the varus knee. But the importance of consensus really is really where there's a lack of science, where there's not the best, most conclusive science available. And the consensus uses a methodology to actually get a lot of experts who've got lots of experience, and to actually use a Delphi methodology whereby they produce statements and answers in a pairing, and they get sent to various other experts, and the questions and answers get changed according to comments made, criticisms made. And there were 26 European experts involved after the initial osteotomy expert group set up the questions and answers, and then these international societies were invited as well. So you had more than 50 acceptances from European experts from those societies. We had over 90 experts from around Europe using this Delphi methodology to focus down these questions and answers. So when it comes to having a sense of being able to push forward, there's always been sort of myth that you can't operate on a woman or you can't do it on an old guy or whatever. But we got together, and these are the answers that we came up with. And each question and answer has a level of evidence, and generally speaking, because we're talking about a consensus issue, it's a low level of scientific evidence in the journal, but it whams up when it's seen in a consensus way with a lot of experts, and that increases the level of evidence somewhere up with systematic review. So we were quite clear, because there is no evidence saying that you shouldn't operate on people over the age of 55. It has to be for the right indication. It has to be for the right match. But there is no unwritten law that you can't do that. And neither is there an unwritten law that you shouldn't operate on a woman, especially a woman over 55. I've operated on many postmenopausal women with excellent outcome. So there's not a rule to say that thou shalt not. So what about the intra-articular deformity? And we've talked about the joint line convergence angle, and we know this is a soft tissue phenomenon which relies on alignment. Once you correct, then that little opening there, that JLCA, will shift and will change. And if you haven't accommodated for it, then you'll find that you'll get an overcorrection. So it's important that we address these issues, and we had a consensus on that, a high agreement of 8.5/9, and there are methods described in the paper which will show you how to calculate that. One of the things that Liz asked me was, is there a target? Well, we do have a target. Various targets have been asked or have been suggested over the years. Between 50 and 68% are published. But we're worried about secondary deformities. We're worried about overcorrection. We're worried about distorting that MPTA, completely changing the morphology of the proximal tibia. So the general consensus, again, was to keep to the low side of that correction, although in some studies have suggested a bespoke correction, depending on what exactly you're trying to treat, whether you're valgizing a limb simply to offload a meniscal transplant or some articular cartilage surgery, or whether you're treating a 55-year-old with stonewall severe medial compartment osteoarthritis. What about the orientation of the joint? We talked about this morning, and of course, I'm not going to make a big deal of this. We can't really say with real confidence what joint line obliquity is, but we can say what an MPTA is. And I think that's probably where we should be coming from until we standardize the other measurements. And another question which we're going to talk a little bit about double level osteotomy. When would that be indicated? And really, when you've got two deformities above and below the knee, if you've got a bifocal deformity and they're sizable, then I think it's realistic and reasonable to correct. There's nothing wrong with doing it all at one level still. If you're keeping things within a reasonable, what I would call the green window, when you look at on the trauma CAD planning tool, green is the good area, and then of course red, you're stepping out of the normal zone. So if we keep it in the green zone, single level is fine, but if you've got big corrections, we would advocate going on to double level. So we'll just move on to the next one. So this is an example of double-level osteotomy, Philipp Schuster in Stuttgart, and they had a great series of 48 double-level osteotomies. Here, if we look at this view, you can see in picture C what happens if you do all of that osteotomy in the tibia, and picture D, what happens if you do all of that osteotomy, all of that correction in the femur. And both show oppositely directed poor joint lines. If you do that osteotomy above and below, you keep a nice horizontal joint line. And with good planning on soft tissue planning systems such as TraumaCAD, Medicad, and others, then you can get a really good calculation for getting a horizontal joint line. Of course, you can do the same with a PSI as well if you wish. This was the results of his paper, and there you can see in the post-op figures, those circled values, those two values are all sitting within what we call the green zone, in the normal range for adults. And look at that, all patients would have surgery again. I've met Philip, and he's an honest person, and this is absolutely good data. That's a really impressive statistic. 2-level osteotomy. So I was also asked to talk about what things can sort of spoil your results. So there's no doubt that osteotomy in the current era is a different animal than it was way back in the 60s and 70s. This paper published from Nottingham in the 70s describes over 200 osteotomies. And just look at the pictures to know what the sort of gravitas of what could go wrong with an osteotomy meant back in those days. And then the figures there showing you 3 deaths, DVTs, PEs, deep infection, pretty horrendous, People were queuing up for this sort of thing. It was all different levels of osteotomy, but this is an honest report and it tells the story. Nowadays, it's different. It's a lower complication rate. We should never try and diminish the severity of complications. And somebody said today, there's nothing perfectly safe, and that's true. But these serious complications are much lower, and it's all about safety and things like consensus and science coming together to improve those safety rates. But the hinge fracture is still out there, and it's classified according to Takeuchi, who actually found the type 2 fracture was probably the most difficult in causing secondary operations. The type 3 you should sort out at the time, and that's at the time of surgery. The type 2, this is one that went under the radar in my clinic. It's my surgery. I got the surgery wrong. And on the right-hand side, you'll see the green line, the mechanical axis, shows that I've lost my correction. That green line was actually in the right place initially. And that's because, if you look at the picture on the right, the osteotomy line should have been where the yellow line is, and it's where the red line is. And that's why the type 2 fracture occurred. So it's so important to get that hinge point bang on every time, because where you put your wire is actually 3 millimeters above where the saw is going to cut. So you have to put your wire 3 millimeters above where you want the hinge to be. Why do we get type 3 hinge fractures? Well, that's because we don't cut the posterior cortex. We're getting a bit, I'm not going around the back, there's vessels around the back, I don't want to do that. So you've got to engage and go for it. You've got to make sure you're trained, you're doing it safely, you're using the right tools, you're using the right retractors, or you just don't do the operation, simple as. If you don't cut that bone, then as you open, that's what happens. and then you get that. All my own work, this is mine as well. So you have to take everything out again, put that screw across there, and then do your osteotomy. And that was 6 weeks, and he's not had a trace of a problem since. But you shouldn't make that mistake, because you need to cut the posterior cortex. Hinge wires are very helpful in protecting from hinge. This wire initially came almost by accident with the PSI, and then they found using that wire actually stabilized the hinge, so it became a thing. And it's a really, really helpful tool. I don't use it very often in HTO unless we're doing a very big opening, but it can be particularly useful above the knee joint. But just see how that wire has bent. You can see how it's taking up the force as you open up that osteotomy, and it's protecting that hinge. However, I use it for every single double-level osteotomy now, and every single DFO, I use a hinge wire. And it's because of these sorts of data which suggest that if you crack that hinge on the femur and it displaces, you're very, very at risk of malunion, really at risk. And this is another paper from Andreas Imhoff. We mentioned him twice this morning. So I always pop this hinge wire in. It's not difficult to do. It just takes a bit of practice. Every single DFO, and this really gets you out of jail, stops it happening. You can see how you can move the hinge, you can open and close, and it's nice and stable with the presence of that wire. So drawing on my own experience causes the problems during the years have been incomplete planning. Planning's so important, everyone's mentioned it today. The joint line convergence angle was a problem, but now we consider it. We have a methodology for dealing with it. And hinge fractures. And what about the question of unicompartmental knee replacement or high tibial osteotomy? That's a question often asked at osteotomy courses. They're basically two different animals. I don't think there's that much overlap between the two. If we've got young and active, it's osteotomy. If we've got an intra-articular deformity, almost regardless of the age, then it's going to be a unicompartmental knee replacement. We can talk about that at coffee if anybody's got any questions. Finishing off, I was asked to talk a little bit about registries, and there are registries in Europe. UCOR is a United Kingdom version. I was involved in its inception. It's difficult to get data out of at the moment because the guy running it has got other things on. But it's an incredibly useful tool, and I've chatted to Hemant about that and how we might get some more data from UCOR. But the German groups and Swedish groups have also done this. So this is the sort of data set we collect, and unfortunately there's something only like about 20% in the UK are actually subscribing to UCOR, so we're not getting a full bandwidth of cases, but we are getting a good sample. So EQ5D, Oxford knee, and KOOS, but a lot of radiographic data is fed in as well, and MRI and CT data too. So it's a huge collection of data which we can tap into. And this is just an example. This is the typical age of osteotomy patients. It's not, I think something's come out in the graphics here, but the big group there is osteoarthritis in green, which is 1,500 at the time this was done. It's now something like 7,000 or 8,000. And the major part of the major groups are actually more than 50% are Keller and Lawrence 4 and 5. So this is not all early disease, but I think the distribution is changing now with more and more osteotomy being done for cartilage work and slope change now for ACL. Just being two examples of things which are becoming more prevalent. But just one thing to draw your attention to on the subject of double-level osteotomy. These are the results for 6 months, 1 year, and 2 years. This is VAS score for HTO. Notice the change across the 3 bars there. This is distal femoral osteotomy. That's the change across the 3 bars. And there's double-level osteotomy. Look at the consistent improvement. Small numbers, but a trend. Same with mean change in Oxford knee score, HTO across the 3 periods, 6 months, 1 year, 2 years. Distal femoral osteotomy, but then looking at double-level osteotomy again. So we haven't got scientific proof to really nail this, but we have good suggestion, good evidence that a little bit like that kinematic knee discussion earlier on, that this is perhaps going to produce better kinematics in a patient nearer to their normal because you're keeping that joint line somewhere at the right level. So thanks very much.